Many orthodontists throughout the world, in the Far East, in Europe, in Latin America, and a few of us in the United States, are treating severe skeletal malocclusions without orthognathic surgery and without the need for premolar extraction. I have been using this philosophy for 20 years. Now my life is a lot easier because of the advent of GUMMETAL. GUMMETAL is a unique alloy. It's the ultimate orthodontic wire. It's made out of titanium and niobium, and it exhibits all the ideal properties that you want in an orthodontic wire. It's got a low Young's modulus while maintaining high strength. And this is two properties that do not exist in any other metallic compound or alloy. So it's a unique wire and it affords all these incredible benefits. This is a class 3 open bite. This is the nemesis of our specialty. This definitely is usually a two-jaw surgical procedure. You can see that there's almost one tooth class 3 discrepancy. You can see the moderate amount of crowding that we have. Distally uprighting the teeth to create space for the crowding. Well, most crowding cases not only have that mesial buccal inclination, but they also have lingual inclination. So by uprighting buccally and distally uprighting, we make room for most crowdings. These are the new GUIA wires. This design was by Dr. Velasquez Torres, and it's very simple because we avoid having to put the loops on the back, which still some cases required, but most cases we get away by doing this. And here we have a short anterior vertical elastic and a short class 3 elastic. We never use an elastic more than one tooth. And here we show the elastics that we wear. And as we begin to close the bite, we've already established a new mandibular position. The mandible already adapted into a class 1 relationship. Now, to maintain the steepness of the occlusal plane, we need to start bringing the posterior teeth up, which we do by beginning to straighten out the wire. And here we do like step-ups to get the final occlusion in the back. This case took 22 months. She was a great patient. She wore her elastics. When they don't wear their elastics, us all orthodontists know it's only a recipe for disaster. So you gotta motivate them. But with this type of treatment, they're motivated because the results are so rapid. Within one visit, within 1 month, the bite closes, the mandible begins to adapt, so it motivates them to wear the elastics. Look at this tremendous facial change that we obtain. We're rearranging their face. And here you can see, again, the mesial inclination and how we upright it and how we adapt everything back. She already had her third molars out, but you can see that the super eruption of the second molar almost acts as a functional device, forcing the patient to bite into class 3, and then the whole system grows that way because of the position of the teeth. And again, I like these images of the skeleton because it shows you that it's not only a mandibular repositioning, but there's a tremendous facial improvement when we do this type of treatment. And here you can see we're retracting the mandible. It goes counterintuitive because we're taught that to open the airway you have to advance the mandible. Well, here we're adapting the mandible back, and look how much airway we get open. And again, most of my cases react this way. The other one was an outlier, I believe. And again, we're not driving the joint back into the joint position. Basically, it's the same. The mandible adapts down and back. So here, let me show this class 1 open bite. Horrendous malocclusion, right? This malocclusion requires 1, maybe 2 jaw surgery in most orthodontists' hands, but in reality, it's a very easy malocclusion to treat. Here you see the open bite, moderate crowding, and this is a finished result. In 24 months, we get this kind of result. We're able to align. Here on the cephalograms, you can see the mesial inclination of those teeth, and look how we uprighted them as we close the bite. Here we have another open bite. Again, this is almost intimidating to many people, but it really is a simple malocclusion to treat, especially this one that has very minor crowding. We just have to round out the arches a little bit and develop the arches. And here we go. Again, the wires, see, this one has loops in the back, and this in 21 months. In reality, I'm disappointed that we didn't do it faster, because when you don't have to spend 6 months leveling and aligning, we should have been able to do this in under 18 months or even less. Before the multi-loop wires, we used to make them out of stainless steel, and then we moved on to alloy. Patients that I switched over from multi-loop to gum metal tell me that the sensation, the feeling, it's less painful, less bothersome, and obviously not having all those loops makes the oral hygiene a lot better, a lot easier to clean. The patients accept it better, and it definitely, from a clinical point of view, it's a lot easier to bend the wires and activate them on the go as we need to. At the end, when you're finishing the cases, we can apply the finishing bends very easily because of the flexibility of the wire, and yet it's got the stiffness that you need when you're finishing the cases. So to me, it's the overall best ideal orthodontic wire. Gum metal is a wire like no other.